Hello, this is Dr. Lauterbach, and this is the Geriatrics Key Point mini lecture. The focus of the assessment of the geriatric patient occurs in three areas: the medical status, a lot of attention to their functional status, and their psychosocial status. The medical status the approach is very similar as it is in all adults. But there are diseases that they are going to be at higher risk for as they age, including cancers, cardiovascular illness, neurological changes that come on in older age more commonly. A lot of attention to their functional status. How well are they getting along in their activities of daily living? Are they able to accomplish the things that they need to do to maintain a safe and living pattern? And also, are they able to do the things that they enjoy doing? And then their psychosocial status. In the adolescent lecture, we showed Erickson's stages. I won't redo that here, but generativity versus despair is a concern. But isolation, which can be a result of a number of different things: loss of spouse, loss of partner, loss of friends, reduced physical stamina, social isolation that comes from children moving away. A lot of different things can impact it, but depression is a major concern, and especially among men, suicidal risk is fairly high. So it's important to find out how happy people are. And we have a number of different tools that you can use in your geriatric assessment to get at that. So you'll do a history and physical, look at the functional capacity, and then cognition, their ability to process and their ability to remember. Look at their pharmacological situation. Polypharmacy is common, and it can create a lot of the deficits that we see in geriatric patients, and it would be a shame to attribute that to an underlying condition when in fact it is drug-induced, and that can be managed. So a thorough reconciliation of medicines, and using Beer's list and others that you learned in pharmacology, looking for things that could be impairing their functional or cognitive abilities is important. Social, kind of touched on that in the last slide, and environmental. Are they in a safe environment? And some of that is very basic stuff. If you've worked with a geriatric population or home care, hospice, and so forth, basic needs need to be addressed. Can you get to the toilet? Can you get food and feed yourself if you live alone without supports? Can you get out of the house if it catches on fire? There are important things to know. And then, of course, the trip hazards and things of that nature. Is it a safe environment? Is there violence there? Is it likely you're going to be victimized by that violence? All of these things need to be considered in doing that assessment. The approach to a comprehensive geriatric assessment is typically multidisciplinary, with physicians, nurse practitioners, PAs, social workers, sometimes neuropsychologists doing testing, and nutritionists taking part to put a comprehensive picture together of the geriatric patient's current state, and also to put a plan together to help them achieve the things that they want to achieve in their life to the best of their ability and within the realm of reason. You will use standardized assessment tools in a comprehensive approach. And then have a medical problem list, which includes health maintenance and health promotion. In approaching these people, it's important to consider what is relevant and not relevant. Well, why is that? A couple of reasons. But the best reason is you will wear out these patients with too much process, too long a visit. They don't have the endurance for it. They will become distracted. They will become disinterested. They may even become angry. So that's a very important reason to stick to relevant, not the non-relevant. And the other one is more self-serving to us as providers, is you're wasting your time. There's no reason to go through that. You're going to be busy. You have a lot of patients that want to see you. You need to keep things focused. But the big reason to stay relevant is it needs to have an impact on what you're going to do in terms of diagnosis, problem development, and planning. And if it doesn't, then don't take time doing that. It's a burden on the patient to do that without any real likely benefit. So what's relevant? Occupation, environment, functional level, lifestyles, the changes to lifestyle, advanced care planning, and finances. What do we not need to worry about now? Childhood illnesses. They pretty well played out. Family history. Really important when you're younger to know what did you inherit, or what is it possible that you inherited that sets you up for higher risk for diseases. By the time you're this age, that's pretty much played out. You don't need to worry so much about that. So you want to stay focused. We're going to have a review of systems, focusing on range of motion, balance, falling, and stiffness, safety issues, hearing and visual changes, which are part of aging, but are there ones that either are beyond what's anticipated in aging and indicate there's some pathology, like a brain tumor, or are there do we need to develop a plan for some adaptive aids with hearing or vision? Elimination, nocturia, frequency, incontinence, and constipation. The general is important. Appetite, fatigue, weight changes, pain, sleep. Pain is often overlooked in the elderly, and they often don't complain about it. They have an impression that pain is part of aging, or it comes on so gradually they don't really realize the burden it's placing on them. But it's very important to pursue, do you hurt? Do you ache? Expect the patients will minimize that with you, and encourage them to describe it as well as they can, rather than just pass it off as something that they've come to accept. And then the emotional component. And I would say also the spiritual component. How happy are you with your life? How are things going compared to the way you wanted them to go? And don't expect that you won't uncover that people have disappointments. If they have disappointments, how are they coping with the disappointment? How do they integrate that into the story of their life? These are important things to ask old people. Physical exam, you'll use some additional tests to evaluate functional and cognitive level, and as it says here in the slide, attend to their safety. There's a get up and go test, which is an excellent screening test to determine if people are having a difficult time with movement. The get up and go test really helps you see past any of the compensatory things that those patients may be doing to make movement in the general way not appear to be as limited as it really is. Then there's the Tonetti balance and gait test, the reach test, and looking for resting and intention tremors. Neurological, do a mini-cog, mini-mental status, MoCA or CAM to identify their mental status, and then the geriatric depression, and know the difference between delirium, dementia, and depression. You need to understand what is expected physiological changes seen in aging and what is pathology. Either way, you want to build a plan to optimize these patients' ability to achieve the goals that they want to achieve in their life.